Shall I start? Or they're giving a countdown. Start.
Yes, ma'am, start.
Good afternoon, everyone. On behalf of PACS team, I welcome you all for our third module of PG Connect, where we discuss a disease-specific module. So today we have come with the most dreading disease which has been there with us for few decades, I would say, where we have been trying to swap it off, but we're finding it difficult. So let's look into the tuberculosis, which each and every specialty, not just respiratory medicine, comes in contact with the patients of tuberculosis. Now, I have a constellation of esteemed faculty today for our third module on TB, PG Connect. Before I introduce our faculty, I would request each one of you to participate wholeheartedly and please have a interaction going on so that we can know in and about the tuberculosis, and whatever your doubts are, please feel free to ask the questions. And nevertheless, to say there are lots of prizes also for the people who are going to ask the questions. The more questions you ask, the more prizes you will get. We will have a pre-session quiz, but before that, I would love to introduce our faculty for today. We have Professor Karan Madan, who is professor at the Department of Pulmonary Medicine at AIIMS, Delhi. Welcome, Professor Karan Madan. We have Dr. Sanjeev Nair, who is professor at the Government Medical College, Trivandrum, and who also chairs the State Latent TB Infection Working Committee at Kerala and a State Task Force for Medical Colleges in RNTCP in Kerala State. A special word for Dr. Sanjeev because he has been instrumental in making a definitive effect in the policy making as well as for the control of TB, not only in the state of Kerala, but in India as well. Our third speaker for tonight is Dr. Pratibha Singhal, who's a senior consultant at Bombay Hospital and Reliance Foundation Hospital at Mumbai. So welcome, Dr. Pratibha. We have a little change in the order of the talks we will have because of some adjustment we have to do. We'll have Professor Karan Madan speaking his talk first, followed by Dr. Pratibha Singhal. And last, we will have Dr. Sanjeev Nair's recorded talk. Unfortunately, he has to go for some travel, but he has promised that he would be available for the question and answer session. So with this, I would hand over it to Swapna for the pre-quiz session.
Thank you, ma'am. So, this is the third module. I believe everybody knows how this works, but I'll just quickly display the QR code. This has also been sent to all of you on mail, and this is the QR code for the event today. Please scan this QR code, or else you can log in using the URL link that is given here. Once you scan the QR code, you have to fill in your basic details, and then you can participate in the pre-session quiz, which is already live. Also, during the session, please feel free to post your questions uh, or any comments that you may have during the session, which we'll later on pass it on to the faculties for them to take it up during the Q&A session. So please scan this QR code, and we have already made the pre-session quiz live. So that will be live for the next 7 to 8 minutes. So around 3:15, we'll start with the session. Please ensure you take the quizzes and post questions, or upvote or downvote the questions and actively participate throughout the session, because as promised, there are rewards for the active participants. The top 3 quiz winners will be given gift vouchers from PACS, and the top 3 participants for all the 8 modules will get mega prizes from PACS, along with the opportunity to moderate or to be a part of the hosting committee of PACS, Nova PACS, which will happen in August this year. Please scan the QR code and stay on it throughout the session. Ma'am, should we start with the session? We'll have the pre-session quiz live for the next 3-4 minutes, but we can start with Dr. Karan's talk.
Good afternoon, everyone. Am I audible?
Yes,
Yes, Dr. Karan.
Okay, I'll just share my screen. Are my slides visible?
yes, sir. Yes, sir.
Okay. Thank you, Dr. Talwar, Dr. Richa, and the team for this invitation to be among you and speak on this topic. It's kind of, I've made a kind of a basic presentation to give you an overview on this topic, which is very important and often neglected in our setting. And also, as we have some time for discussion, so I think I'll give an overview, and I think I will be happy to take the questions on the topic. So once we talk about post TB lung disease, it's a very common condition, but not very well understood, and people don't recognize it well because many of the times this is treated as active TB erroneously, and the spectrum starts with something called as TB associated lung diseases, which is actually a broad range of respiratory symptoms, which can start before or during the TB episode. Post TB lung disease is when these TB associated lung disease symptoms are persisting after a successful completion of TB treatment. It's important to note that this is a heterogeneous entity, and there are various clinico-radiological phenotypes with varying severity, which you may encounter in practice. So, important to note that successful treatment completion does not stop the disease from damaging the lungs permanently. And this happens because, the mycobacterial, clearing does not, halt the immune response. So even after treatment for tuberculosis, the inflammation undergoes, the mucosal secretions increase. There is an increased systemic inflammatory response. There are studies which are showing that the systemic inflammation is increased, and there's ongoing destruction of lung parenchyma, vasculature, airways, which may be independent of clearing of the mycobacterial load. Very important is that it compromises the respiratory function in nearly 60% of TB survivors. So if you see, this is the actual spectrum of the problem. And what you see is there may be respiratory symptoms, there may be radiological abnormalities, lung function changes, ongoing systemic effects, and importantly, post-TB lung disease is a risk factor for increased mortality. So how do you define it? A couple of years back, there was a consensus process at which it was, tried to define this entity. And post-TB lung disease was defined as an evidence of a chronic respiratory abnormality, which was with or without the symptoms. Important to note, there can be asymptomatic, and they're attributable at least in part to previous tuberculosis. Sometimes it's difficult to have a very clear history of a confirmed microbiological diagnosis of TB. But if the overall profile, matches and the radiological profile matches with the tuberculosis scarring involvement, you label it as post-TB lung disease. Now, this may have, not essentially all the patients will have all the abnormalities. There may be an abnormal lung function. There may be persistent or progressive radiological abnormalities. You may have respiratory symptoms, and these may be these may be alone or in combination. So, what it implies is that it is not essential that you need to have a big radiological scar to label it as post-TB lung disease. So, you may have a lot of small airway obstruction, which may not be very well seen as scarring on the X-ray, but this may be a sequel to tuberculosis. But most often than not, there are radiological abnormalities which are present. This is not limited to the respiratory symptom. There may be cardiovascular sequelae, neurological, psychological, and musculoskeletal system involvement, because many of these patients, are belonging to most of the times a low socioeconomic strata. They have malnutrition. They are sometimes underweight, and the muscle wasting and a lot of other things contribute to the overall symptomatology. Also, there is an increased risk after the development of post-TB scarring, and this can increase the risk of cancer also. So I've brought some few, radiographs from our clinic just to make you, the idea of showing these images is to show that how heterogeneous this entity is. The problem which happens is that whenever you encounter, a post-TB lung disease, people write a blanket diagnosis. They'll write on top of the card post-TB sequelae, post-TB lung disease. But what is very, very important is we should make an attempt to write the degree of anatomical involvement, because this will actually tell you that how severe the problem is. So, say this radiograph, if you appreciate, you may appreciate some, haziness on the right upper zone, which may represent, a fibrotic sequelae of previous TB, but you do not see a lot of, lung involvement in the other areas. So this is something which would, qualify as a minimal or a minor involvement with a tuberculosis scar. So at least one should make an attempt to report the radiograph as, right upper zone fibrotic opacity, or, make an attempt so that we get an idea what is the extent of involvement. Now, if you see the radiograph on the left, now you can make out there are some apical changes in the right upper zone. You can see some pleural thickening happening on the upper zone. I hope you can see my pointer. And then you can also, make out that there are some parenchymal opacities in the upper zone. Subtle opacities are also seen in the left upper zone. So this radiograph would essentially qualify as bilateral predominant apical pleural thickening and also some parenchymal fibrosis in the right upper zone. If you see the radiograph on the right, and now that you can see how pleural thickening looks like, you can see that the pleural thickening is more pronounced on the right upper zone. And then you see some degree of tracheal deviation to the right side and more pronounced right upper zone scarring. So this is, one step further that, the parenchymal changes in the right upper zone are more defined. So as you appreciate, you will understand that every patient with post-TB lung disease is unique. There is a definite or a different kind of anatomical involvement which we should define. And sometimes the extent of involvement would indeed correlate with their symptomatology, but it may not. So, for example, a patient, may have not a lot of scarring on the X-ray, but may be very symptomatic. And this, discordance is sometimes seen. Moving further ahead, now in this radiograph, if you see that the changes are still, more upper zone predominant, but you see they are much more pronounced. You see there are changes of volume loss which have set in. You see rib clouding, but you see bilateral upper zone, fibrotic changes, but you see some cavitary changes also in the right apex. So this would, qualify as more of a fibrocavitary kind of a process. And, I put the CT alongside to show you that how, these cavities are well pronounced. And, if you see the lower left image, you see there are the fibrotic changes and bronchiectatic changes are also seen. So this is actually, we are moving to a little, advanced degree of involvement which is happening, which is very commonly seen. And if you see this kind of radiograph, you would make out that this patient is more likely to be very symptomatic. Again, as I said, you should make an attempt to define the disease once you write your diagnosis. Don't just leave it at post-TB sequelae, post-TB lung disease. Make an attempt to, you write the anatomy so that one can understand the extent of problem. Now, if you move further, on the course, the radiograph on the left, actually shows you that there is obviously a major abnormal process happening on the left side. You see the whole trachea has got deviated to the left side and there is a lot of volume loss. And you see partial foci of, aeration in the right lung. And also you see some degree of, a well-defined opacity seen, probably the relation to the fissure on the right side, maybe some fibrotic change or a, loculated or a healed sequelae of a collection, of pleural collection. So this is what is called as something as a unilateral destroyed lung phenotype. So this is a post-TB destroyed lung. And also if you see image on the right side, the destruction is more pronounced and you hardly see any radiation ongoing in the left lung. Important to note, you will see these, sequelae changes also in the right lung. It's very commonly seen that if you have a destroyed lung, you'll see these fibrocalcific sequelae on the contralateral. And also you see some lung also. These patients are, at the extremes of physiological compromise. And, they have very poor lung reserves and usually are quite symptomatic. So if the disease, moves to the pleura, you will see varying degrees of post-TB pleural fibrosis from a mild to moderate, sheet-like, you see this pleural thickening to a, calcified empyema-like collection or a very large calcified sheet-like collection as you see on the extreme right image. And this actually also shows the development of cancer or lung cancer in relation to the pleural thickening area. So, airway obstruction has been, well studied in post-TB sequelae. And, many patients, nearly one-fifth would have airflow obstruction. And small airway dysfunction is virtually seen in nearly half of the patients. And as I mentioned, the chest X-ray may not look bad, but sometimes the CT may show extensive lung trapping, the air trapping, and, small airway disease. So I would like to, briefly present, some work from our center because, the large sample data of post-TB sequelae, which have studied the clinical, radiological, quality of life profile from our country are lacking. And this would give you a picture of, what the kind of profile we see at a tertiary level center. Important to many of these patients are, relatively kind of younger. They are not too old. The mean age was around 44 with an equal gender predilection. And you see, majority were non-smokers. A large majority, nearly three-fourths were non-smokers. And females who had this, many of them had ongoing biomass smoke exposure. You see that this is how they were diagnosed. And many of them had received multiple courses of ATT in the past. Usually a median, most of them had, 1 to 2 courses which they had received. And the mean duration of antituberculosis treatment received was around 9 months. But important to note that, there was a delay in appearance of symptoms in majority of the patients. So from the first antituberculosis therapy treatment completion till the symptoms, the median duration of symptom development was close to 3 years in many of them. And most of them had been treated with a first line treatment regimen, and most of them had been compliant to their treatment. So this means that post-TB sequelae is not a sequelae of, poor compliance. People will be taking their treatment, but despite that, they will develop sequelae. Out of symptoms, majority had cough, expectoration, and dyspnea. And as ours is a tertiary care center, we have a lot of referral of patients who have hemoptysis. So nearly 60% came to us with hemoptysis, and wheezing was not very, very common. So this was only seen in 16% of the patients. And the median duration for which these patients have been symptomatic was close to 4 years. So since 4 years, they were going on with symptoms, being misdiagnosed as TB, being given repeated ADT and not getting the right treatment. And they had persistence of symptoms following ATD completion. Regarding treatment, many of them were on varying combination of inhaler therapy. Majority did show some response to inhalers, and as many of them were referred to us for hemoptysis, and a bronchial artery embolization procedure was performed in many of them. And despite that, hemoptysis was uncontrolled in nearly 8 to 10% of the patients, and surgery was required in many of them. So that is also important that they also require the resources of interventional radiology and surgery for sometime management of the complication. Also, very important to note is that hospitalization is very common in many of these patients, and they also require non-invasive ventilation or may require invasive mechanical ventilation for worsening. And they typically the patients who have a lot of parenchymal involvement or those who have destroyed lung or extensive fibrocavitary disease have history of repeated hospitalization. This is very important to note that many of these fibrocavitary sequelae would go on to develop something called as CPA or a chronic pulmonary aspergillosis. And the most common form of chronic pulmonary aspergillosis is the chronic cavitary pulmonary aspergillosis, in which you see these fibrocavitary areas develop areas of increased thickening of the walls with symptoms. And these are all seen in immunocompromised patients, immunocompetent patients, not in immunocompromised patients. So diagnosis of CPA would require, radiographic changes of cavities with or without a fungal ball, and evidence of Aspergillus infection, usually by a serological assay of Aspergillus specific IgG levels and exclusion of alternative diagnosis. And very important to notice that these patients who have ongoing CPA, you should diagnose chronic pulmonary aspergillosis in these patients, because the patients with chronic cavitary pulmonary aspergillosis do require a long-term antifungal. There is data to suggest that a one-year treatment is ideally what they would require of antifungals to control their chronic fungal infection. Hemoptysis is a life-threatening problem in many of these patients. And, bronchial artery embolization is usually a life-saving procedure in them, because many of these have bilateral scars and they are not upfront candidates for surgical management. And they also consume, therefore, a lot of interventional radiology resources for management of hemoptysis. So what to do if you don't have a bronchial artery embolization facility available? Even in a major metro, you may not have centers which are performing VAE as a routine. So we at our center carried out these two studies to see if there are inoperable patients with hemoptysis and aspergilloma. Can an endobronchial installation of antifungal agent work? And both these studies gave us some indicators that in some patients, if you give them serial sessions of intravoncal voriconazole, it does lead to improvement in their hemoptysis and reduction of the aspergilloma in many of these patients. Another very poorly understood and under-recognized form of the disease is a complete or a near complete tracheal or a bronchial obliteration with the TB sequelae, called as post-TB tracheobronchial stenosis. For some reason, this is more common in young people and females. And tracheal involvement and proximal right main bronchial and left main bronchial involvement is common. And very often, the centers which see a large volume of these cases see a complete unilateral left main bronchus obstruction, like in this case, very commonly. And this is the kind of picture which you see. You see on the right is the right main bronchus. And the tuberculosis scar, very different from post-intubation stenosis, just, makes the airway very, very fibrotic and resistant to dilatation of surgical procedures. So this is a very troublesome entity. And, in some patients who have, an openable airway in which you can do some intervention, you can offer them some procedures like a balloon dilatation of the airways at an early stage. So this may help, to recanalize the airway, as you see in the middle image. And, if you're lucky, you may get lung aeration in these patients. So this is a summary of what all you would need to do in patients with post-TB sequelae. You would need to, see their symptoms, do imaging. CT does add to, a lot of useful information on many of these patients. You do a lung function assessment, do a cardiac assessment, because pulmonary hypertension may be coexistent. Take care of their nutrition, exercise. Pulmonary rehab facilities are grossly lacking, but, some degree of rehab does help them. Smoking cessation, taking care of vaccination. So if you see, there are a lot of things which can be offered to patients with post-TB sequelae. You should not just, label them with a dismissing diagnosis that, it's our disease and so, we don't, would do much about it. So it's a disease that we see a lot. It's our problem. So it's our responsibility to, manage and offer the best we can to these patients. So this would be the component of a tailored management. You give them symptom-based therapy, give them bronchodilators, inhaled steroids based on the clinical profile, advise them smoking cessation, immunization, assess the comorbidities, try to give them some sort of rehab, and, management of hemoptysis, may require bronchial artery embolization surgery, or, in select patients, an intrabronchial antifungal therapy. So I'd like to conclude by, these few statements that, as you have seen, post-TB lung disease is not one entity. It is a multitude of entities which have a lot of different clinical and radiological abnormalities. And this may develop long after your treatment for tuberculosis. The symptoms and clinical course may be progressive, and it is indeed progressive in the patients who have a severe degree of involvement. And this also increases the risk of mortality. Hemoptysis is a very troublesome and often a life-threatening symptom. And many patients, they just come in and out of the hospital. I think they have a much worse course than your COPD patients have, because I think these patients, their lung reserves are quite poor, and they do increase the economic and healthcare burden. And very importantly, that you cannot treat PTLD as one way. You have to see what phenotype is there. for each patient, you will have to make a tailored, individualized approach, and then you would be able to, manage them well. Thank you.
Thank you, Dr. Madan, for such an insightful overview of the post-TB diseases. And I understand it was really, really very, very insightful in a way. And we have to be very, very particular about what we are labeling and what we are treating as well. So we have one question for you, Dr. Karan, and it's how much early should we attempt balloon dilatation in our patients of bronchial stenosis, post-TB stenosis, I believe they're talking about.
So very, very important question. So I think first of all, I think we need to recognize that active TB may have endobronchial involvement. So if you see, there are studies from, I think, a large sample size study, especially from China, which have shown that, they did bronchoscopy in all newly diagnosed pulmonary TB. They found some degree of bronchial involvement in close to 40 to 44% patients in some studies. So what it means is that when you are treating active pulmonary TB, you be vigilant for signs of airway involvement. So this would mean doing clinical examination. If you find unilateral wheezing, if you see signs of a focal volume loss or a focal hyperinflation, you do a CT scan early. You would pick up, non-invasively airway involvement, and you may offer balloon dilatation even in the setting of active TB once the stenosis is developing. Because if you intervene even when a slight lumen is present, you may be able to excellently salvage many of these patients. The problem happens is that once, and this is the reality, most of the times we get treated TB when they come with tight stenosis. So when they come with tight stenosis, one thing which we have to do is try to see whether there is a possibility of opening that airway. So we do some manipulation, like you can try to introduce a guide wire or see if the obstruction has happened very, very recently. Like 2 months back, X-ray was okay, and now it is closed. Versus 2 years back, the X-ray is still closed. So I think a time or a temporal course, what you have to see. So I think the bottom line is that in treating active TB, be vigilant about development of stenosis and intervene early. If patient has come to you with stenosis, then you do a good imaging, do a good bronchoscopic examination. And then I think these patients are a kind of more troublesome interventional procedures. So I think better would be to refer to high volume centers where, these things are done more routine.
Right. Very rightly said. And this also emphasizes on the fact that we should be having the regular follow-up of these patients. Uh, uh, Patients coming, with without follow-ups, taking treatments, and they'll end up 8 months taking ATT. They come up with complete collapse of the lung. There is nothing that can be done. So very, very important thing Dr. Madan has put up forward is a regular follow for these patients. And probably when we are starting the treatment, we can tell them about what could be the warning signs and symptoms where they should meet the doctor. So I don't look, is there any other? No, we don't have any other questions. So thank you, Dr. Karan, for your talk and for participating in this Pulmoconnect. Thank you so much.
Thank you.
Swapna, can we, so we would now have Dr. Sanjeev Nair's talk, which is pre-recorded. And following that, we will have Dr. Pratibha Singhal talking about the treatment of tuberculosis, what is new and what is already available. So, yeah.
Can you play the talk?
Good evening, everybody. Let me start by thanking Dr. Deepak Talwar and the entire PAX team for this opportunity to interact with you and for also having selected tuberculosis as a topic for today's Pulmoconnect. Let me start by sharing my slides. So the topic given to me today is the epidemiology and diagnosis of pulmonary as well as extrapulmonary TB. Of course, the time given is quite short, 15 minutes. So in the short time that we have, I will not be able to do full justice to the topic, but I'm hoping that I'll try to cover during this 15-minute discussion the epidemiology of TB in terms of a brief discussion on what is the burden, what are the determinants, and what is the strategy that we have, which is part of what you cover in epidemiology, and also focus a bit on the diagnosis of TB disease, both pulmonary, extrapulmonary, TB infection, as well as how we diagnose drug resistance in TB. So this is a slide which might be very familiar to you. So every year you have these global TB reports, and this is the data from the latest report, which was released in October. So you can see that despite all our efforts, still tuberculosis remains a major public health burden to the world, with more than 10 million cases, that is a crore plus of cases all over the world, and about 1.1 million, that is 11 lakh people dying due to TB in the world. If you add the number of deaths due to HIV, TB along with the TB deaths, tuberculosis still remains the top 10 cause of mortality in the world. Of course, in addition to this, you have about 39, 3.9, I should say, 3.9 lakh cases of MDR-TB in the world. Now, India holds the top spot in terms of all these figures in the world, except for HIV-TB. So you have about 1/4 of the global burden, with about 27 lakh cases every year in India. About 3 lakh people die of TB in India, which is almost 1/3 of the deaths in the world. And we also have 33% of the global MDR burden at about 1.3 lakh cases of MDR every year. It's a huge burden that we are looking at, and it will need a tremendous effort to control or rather even eliminate TB. So where do we get all these data? So it's a good idea to know where it comes from. So on one hand, you have these global TB reports published every year. The current report's a 2025 report, and then you have the TB India reports, national status reports, which again come out every year. So the latest report we had is 2024. We didn't get the 2025 or the 26 report should actually come on World TB Day, but then we're waiting for it. Of course, all these reports have executive summary. So if you are pressed for time, you could just read the executive summary and even try to make out what is there. In addition to these regular reports, you also had a national TB prevalence study, which is the first prevalence study for our country, one of the biggest TB prevalence studies in the world. And this particular study has brought out a lot of information, and also you have state-specific information. So based on which state you're based in, you could actually look at the data. So if you look at the preliminary data that you have from it, you can see that the prevalence of TB in India, the pulmonary TB in India is 312 per 100,000 population, and it varies from state to state. So at the top, you can see it is Delhi with more than 500 per lakh of cases. Where at the bottom, you have my state of Kerala, which has 115 per lakh of pulmonary TB. So it's a huge variation between state to state, and you could check out the figures for your state in the report per se. Even though the study was not powered for or meant, designed for TB infection, but we do have a estimate of TB infection for around 32% in the country. Earlier, we used to speak of 40%. Now you're talking of a figure of 32%. Keep these figures in mind. So I'll just move back and forth between the diagnosis and the epidemiology. So now I'm moving a bit towards the diagnosis. So if you look at the diagnosis of pulmonary TB, which is what most of us deal with. So you start with presumptive pulmonary TB. Until recently, you had this 4-symptom screening, but you should be aware that of late now you have a 10-symptom screening for TB. It's not really covered in this presentation because shortage of time. But then the definitions or the symptoms that you look for in TB have been expanded in India for obvious reasons, which I'll come to later. Also, you have these special groups now, where earlier we had priority for NAT. Anyway, so anybody with presumptive pulmonary TB, which includes cough more than 2 weeks, fever more than 2 weeks, loss of weight, loss of appetite, or in hemoptysis, or even a lesion on chest X-ray, as per the traditional algorithm, such a person has to undergo a chest X-ray and a smear together. Earlier, a smear was given priority and X-ray was taken later, but with the NTP, now you receive smear and X-ray go together. And if the smear is positive, even though the patient starts treatment as part of testing for drug resistance, the patient would undergo a NAT. A patient with a smear negative but X-ray suggestive of TB would also undergo a NAT. And of course, the special groups and presumptive MDR also go to NAT. So in fact, it's like all roads leading to NAT. But then now the program is moving forward, and you have something called upfront NAT, which means that anybody who comes into all these presumptive pulmonary TB or any reason for screening for TB, such a person would first actually undergo a nucleic acid amplification test. So that is what we have now. My district where I actually live, the Trivandrum district, we have already moved to upfront NAT for the last 2 years. So what we have is any patient who is coming to us, pulmonary or extrapulmonary, the first test we do is NAT. And in fact, all the smear microscopy centers in my district have been stopped, except for the ones who do follow-up smear examination for patients already on treatment. The treatment seeking behavior of TB patients is very complex. There's interesting graph that came out of a project that Dr. Matthew did. And if you look at it, you can see that people from the various zones of Kerala, coastal, rural, tribal, and urban, they go back and forth between, government and private practitioners seeking care. And in fact, many of the patients need to meet at least, 5 to 6 practitioners to actually make a diagnosis of TB, which means that often, even though the algorithm which we projected in the previous slide is quite simple, at the end of the day, people do miss tuberculosis. Now, you have a wide range of tests today available for testing for TB as well as drug-resistant TB, starting with the Gene Expert, which is called Expert MDR-RIF, where it's a cartridge base and can simultaneously give you a diagnosis of tuberculosis and rifampicin resistance in 2 hours. New variant of the Gene Expert, the Gene Expert XTR, has been evaluated and endorsed by the National Technical Expert Group, but in the field conditions, not readily available in our country because our NAT machines need a form of upgradation, which is still not done. Then you have the TrueNAT, which is an indigenous test developed by Mall Biotechnologies in Goa. And this particular test also gives you a very fast, 2-hour diagnosis of TB as well as rifampicin resistance. Now, this is readily available, and currently the program has a large number of expert machines and TrueNAT machines. Of course, then you have the line probe assay. Line probe assay is a bit more of a complex test, generally available at the intermediate reference laboratories in the country. This is not really a test for diagnosis, but it's a test for determining drug resistance. So you have a first line probe assay and a second line probe assay. The first line probe assay can give you diagnosis of resistance to INH, rifampicin, and ethionamide, whereas the second line probe assay gives you, results for injectables, second line injectables, and fluoroquinolone. In fact, the Expert XTR cartridge also covers isoniazid, fluoroquinolone, second line injectables, and ethionamide. Doesn't cover rifampicin. So that is probably maybe a replacement for the line probe assay, which would be a faster test. But currently, the program depends a lot on the line probe assay. Of course, the labs, the intermediate reference labs located in multiple labs in many states of India, most states of India, have predominantly liquid culture now. The MGIT machines have come in a big way. We actually have MGIT machines, which actually, sorry, let me go back. Which gives you results slightly faster. It's a liquid culture is the test of choice for extrapulmonary TB for TB diagnosis. And also, for certain drugs, you need to do a liquid culture to make a diagnosis of drug resistance, for example, for bedaquiline or, linezolid. And also, it's used for that. Solid culture is slowly being phased out, even though it has got its own advantages. But I'll not go into the details of that right now. We also have something called UDST or Universal DST, where every patient should have the right to know at least rifampicin resistance status and, if possible, resistance to other drugs as well. So it all starts with a nucleic acid amplification test. As I said, it could be a TrueNAT or a CBNAT. And with that, you get rifampicin resistance. So if rifampicin resistance is present, you go further with the first line probe assay, which gives you INH, rifampicin, and ethionamide resistance. A second line probe assay, which gives you second line injectable and fluoroquinolone resistance. And MGIT for other drugs like linezolid or high dose moxifloxacin, maybe bedaquiline, delamin, as well. And based on whatever results you have, a patient gets an individualized regime. It's not part of my talk, so I'll not go into details of that. If rifampicin resistance is not detected, such a person should undergo a first line probe assay, which will give you INH, rifampicin, and ethionamide if needed, of course. But in this case, you're looking at INH predominantly. And if INH resistance is present, you have a regime for that. And if INH resistance is not present, the patient gets a DSTB regime. So this is how the program, evaluates for drug resistance. Of course, the classification of TB with the availability of nucleic acid amplification tests has changed. So earlier we used to speak in terms of, smear positive pulmonary TB, smear negative pulmonary TB, and extrapulmonary TB. But today in this NTEP era, you talk in terms of microbiology confirmed TB, which includes NAT positive or a culture positive or even a smear positive TB or clinically diagnosed TB, where you diagnose based on, say, X-ray or histopathology or things like that. The program earlier, the RNTCB used to focus a lot on pulmonary TB, but with the NTP, we're looking at, all forms of TB, including extrapulmonary TB as well. In the good old era of when RNTCP started, our estimate for, extrapulmonary TB was somewhere around 15% of the TB. But then we find of late that almost 24% of the TB, one-fourth of the TB in India, diagnosed in India as extrapulmonary. There are many states in India, including Kerala, Himachal, and many other states, have a much higher proportion of extrapulmonary TB of somewhere around one-third plus of patients having extrapulmonary TB. And this proportion has been increasing both at national level and my state. And many of us work in institutes, which are tertiary care centers. And there, in fact, the proportion of extrapulmonary TB is more than half of the TB diagnosed. So for us, it's more of extrapulmonary TB than pulmonary TB that we see at our level. And you have the various forms of extrapulmonary TB, which are seen. The commonest one, of course, is lymph node TB, followed by pleural TB, then going on to abdominal, spinal, TB meningitis, and so on. And almost every other organ is involved. Now, for diagnosis of extrapulmonary TB, the criteria for suspecting would vary from organ to organ. Symptoms may be different. The main question we ask is, can we get a tissue for testing? So generally, for a lymph node, a pleura, and all, you can get a tissue easily. And if a tissue is available, you do a NAT, a histopathology, and a culture wherever, at least for the precious samples that you have. We call it a precious sample if you cannot get a sample again very easily. For example, a tuberculoma or a spinal sample and all, that's not something that can easily repeat. Whereas if it's a lymph node FNAC or something like that, you could actually pleural fluid aspirate, can be repeated again. So in such cases, when the sample is precious, you go in for a culture also initially. So if your NAT or your culture is positive, you call it microbiology confirmed TB. Whereas only if your histopathology is positive, NAT and MTB do not detect the bacteria, then you call it clinically diagnosed TB. And in those cases where a tissue is not available, for example, a spinal TB, the orthopedician may not be willing to dig in for tissue, and they are based on MRI, if he's making a diagnosis, it's called clinically diagnosed extrapulmonary TB. We should understand that NAT is a very good test for extrapulmonary TB. In fact, only gene expert or the expert MTB RIF is actually endorsed for extrapulmonary TB, but in programmatic conditions, often even TrueNAT is used. And the point to remember here is that if you look at this column here, the second last column, you can see that whenever NAT is done, the yield for NAT in extrapulmonary TB is quite good. This is our data from Thrissur. Whereas in most cases, NAT is still not done. The doctors treating extrapulmonary TB are not aware of the need for NAT. And since NAT is not done, the yield of NAT in such case of extrapulmonary TB in practice, clinical practice, is often low. Remember, that is not because the test is not good, it is because the test is often not done. Coming back to our results, which I showed you earlier, so you have about 32% infection in India and a varying proportion of disease in India. But even in a state like Kerala, where the disease prevalence is low, we should remember that a significant proportion of the population still remains infected. So even in Kerala, in the adult population, about 20% of the population is infected. And with the TB elimination strategy that we have, it is necessary to also address these infected people. So you also need tests for diagnosing TB infection as opposed to TB disease that we discussed earlier. And for that, the tests are the quantiferon TB Gold and tuberculin skin test. Tuberculin skin test is not really available in India. Standard solution is not available in India. So currently you have a new skin test called the CYTB, which is readily available in the program conditions itself now and has been rolled out initially for adults, but it's slowly being expanded to children as well. So if you do one of these tests and comes positive, it becomes a TB infection. But we should remember that these are not tests for TB disease, and you should not even attempt the test for diagnosing TB disease. These are only tests for infection. Even the concept of infection and disease, which we had earlier, where we had a black and white border between TB infection and disease, has now changed, and you have more definitions coming in of incipient TB, where the disease is actually progressing but still not manifesting clinically, and subclinical TB, where the disease can be picked up on certain tests, but the patient is asymptomatic. So it starts from eliminated TB to latent TB to incipient TB to subclinical TB to active TB disease. The definitions are there, but since I'm running out of time, I'll not be able to go into details on that. The strategies have been evolving. I mean, now in the NTV strategy, where the targets are very stringent. And to reach this target, we have to think out of the box and do very new things, which currently we are not doing. Again, time doesn't permit me to go into that. But I would like to say that the last global TB report shows that we are very far away from the targets which were set. So, in fact, like for example, for incidents, you have 50%, you're supposed to have 50% reduction. You have only had a 12% reduction by 2025. For each of the targets, we are much behind what we were supposed to achieve. Now, each of these targets, strategies which can be used to achieve them are quite simple, which also include early detection of cases. So suspecting cases and diagnosing them with appropriate tests is one of the important strategies needed for each of these points. But the one I would like to focus on right now is reducing incidence. And if you're trying to reduce incidence, remember the TB preventive therapy. For that, you have to diagnose TB infection, as well as addressing factors which lead the infection progressing disease is also important. And only if you do that, the success of the TB control program going into TB elimination program will be fully evident. So if you look at our strategies in the past, we thought that patients would have symptoms, they would all seek care, and they would the most infectious ones would be picked up on microscopy. But now we find that about 40% of TB patients in the prevalence study that we had do not have symptoms. Most of them do not seek care. Even in the best health seeking behavior in Kerala, only half the patients actually seek care, and only for 42% can be picked up only if your X-ray is done. So X-ray has become a very important tool, and you're also looking for newer markers which allow for diagnosing those cases in which infection progresses disease faster. So you have these X-ray vans available all over the country, and you also have these handheld X-rays which are now being rolled out in big numbers. So X-ray is making a comeback with a bang. The other point that is necessary is to address those factors which lead to progression of infection and disease. In a meta-analysis or a modeling done by Longrath et al., you can see that for the 22 high-burden countries where they looked at, malnutrition was a major cause, followed by HIV, followed by diabetes, smoking, and indoor air pollution, which are the major causes for infection progressing disease. We have done our own modeling like this in Kerala. Again, we find that undernutrition is a major cause, but our major factors are recent close contact, diabetes, tobacco, COPD, and all, as opposed to HIV in that 22 high burden countries. So each state can do their own analysis. And once you identify which are your factors, those factors, there are two ways of approaching it. Either you start screening these people with these vulnerabilities to pick up TB early, or you try to manage these vulnerabilities and you try to ensure that TB does not occur. So there are two ways in which a public health strategy can go. So even though I'm finishing my presentation, we should remember that this is not the end of it. Newer tests are coming up. For example, in this list, the targeted next generation sequencing is coming up in a big way. It is being implemented in many countries, and we are looking at that coming in a big way in our countries. So many new tests are coming, and it's still evolving. So I'll conclude by saying that we still have a huge burden of TB, with India having the largest burden. Strategies are evolving, and there have been newer and newer tests coming up. So we have a lot of tests which are of the best quality in the world, available free of cost in our country through the program. And also you have more understanding of the epidemiology, which may help us to eliminate TB better in the coming future. Thank you. Thank you for the patient listening, and I'll be open for questions. Thank you.
Thank you, sir, for your wonderful talk, as always. Swapna, is Dr. Sanjeev Nair available?
Yes.
Yeah, I'm there.
Okay, sir. Thank you so much, sir. As always, it was a wonderful talk, and we feel more inspired about, yes, TB will be eliminated from the country in due course of time. Do we have any questions for Sanjeev, sir?
Nothing.
He's traveling, so we don't know when his connection will go off.
Nothing related to this talk, but yeah, there was one question from the previous talk. Actually, two, three, which probably sir can also take up.
Okay, so I think, Swapna, those questions we can take it in the last.
Yeah,
Because Is Dr. Karan available? No, Dr. Karan has left. So I think
Yeah.
we'll take up those questions in the last when all of us are there. So as for now, sir, Sanjeev sir, no question for you. And thank you so much once again to join
Thank you.
in person as well while traveling. And thank you so much once again. Is Dr. Pratibha?
Yes, I'm there.
Hi, Pratibha. Yeah.
Yeah, so may I start?
Yes, ma'am.
Yes, okay. So thank you for having me here for this interesting topic. So while the topic says recent advances in management of pulmonary and extrapulmonary TB, I'm also going to cover some of the things that we already know because it's obviously a continuum of what we are learning. So to recapitulate before we proceed, some definitions. Presumptive tuberculosis refers to a person who has any symptoms or signs on an X-ray chest to suggest which could be suggestive of TB. Drug susceptible TB would be a confirmed or a presumed resistance. Monoresistant TB would be to any one single first-line anti-TB drug only. Polydrug resistant TB is a TB that is resistant to more than one first-line anti-TB drugs other than HNR. Isoniazid resistant TB is that what is resistant to only INH, and MDR TB is resistant to both HNR, irrespective of whether it is resistant to other first line drugs. Now, pre-extensively drug-resistant TB would be somebody who is resistant to both HNR, that is fitting the definition of MDR, plus resistance to any fluoroquinolone. And an extensively drug-resistant tuberculosis or an XTR TB would be someone who has resistance to HR, any fluoroquinolone, and at least one additional group A drug, for example, linezolid or bedaquiline. So this is something that we should all know because when we screen patients, when we look at the reports, we need to be able to categorize them well because that is going to define how we are going to subsequently treat them. Now, once we have given treatment, these are also some definitions to remember because when you have patients who have received treatment outside and are coming to you on follow-up or for having symptoms again, you need to be able to categorize them whether they have their treatment failure, basically where their treatment needed to be changed or terminated early. Then you have a patient who's cured where there has been a bacteriological response, right? And there is no evidence of failure. Treatment completed is when a patient has completed his entire duration with the correct doses, with everything correct, but where you do not have evidence of a bacteriological cure. So sometimes you have, especially in extrapulmonary TB patients, where you cannot have samples for cultures again and again. So usually in those patients are where we use this word as treatment completed. Loss to follow-up was somebody whose treatment has been interrupted for 2 consecutive months or more, right? Now, why are we talking about this? Because we know we are looking at TB elimination. However, we are still far from there because we still do have a lot of drug start treatment early is because one is we're decreasing the spread to somebody else, we're decreasing the development of resistance. And of course, you've heard Dr. Karan, now we are not only now that we are treating TB a little better, we are seeing more and more post-TB issues after patients have been declared treatment completed or cured. We are seeing a lot of post-TB cases. So that of course, if you don't diagnose them early, you're going to result in more lung damage. And of course, to decrease the deaths due to disease. So anybody who's coughing for more than 2 weeks, fever, weight loss, hemoptysis, or any other non-specific symptoms, and with a chest radiograph that could be consistent with the TB diagnosis, whether it's nodules, whether it's consolidation, cavity, mediastinal enlargement, anybody you would suspect a TB patient. So this is the basic thing that we all know, right? About what are the doses for anti-TB drugs. This hasn't changed much in first line anti-TB drugs. No longer do we use streptomycin, only in specific conditions like TB meningitis, sometimes when the patient is not doing well and you need something which has better penetration in the meninges, or when you have to replace a first line drug because of a ADR. So for our drug-sensitive TB, our treatment regimen is still what we have been following, which is an intensive phase of 2 months of HRZE in daily doses as per the weight, followed by a 4-month daily regimen of HRE. So what are the weight bands that we follow in the National Control Program? It's basically available as a fixed dose tablets, and for the weight band category of 25 to 34 kgs, you give 2 tablets of the IP phase and 2 tablets also in the continuation phase. And similarly, with each weight band increase of 10 kgs, you keep on adding 1 tablet in each category. Please remember that the weight should always be checked when the patient is coming to you monthly or on follow-up, because if there is any change in the weight band, that means if the patient has lost weight or gained weight, you may need to change the doses, because otherwise you may either be causing side effects because of over medication, or you may be making the medication inadequate in inadequate doses if the patient has gained weight. So let's look at some cases. Now, this is a 35-year-old male who's a non-smoker, having cough with expectoration for 4 months, feverish, not really documented fever, having, of course, loss of appetite, loss of weight, has been having a history of irregular anti-TB treatment taken for 4 months in 2018 and then 3 months in 2020. On presentation, patient is sent for an X-ray and a sputum AFB. Unfortunately, he does not have any old records other than this history. So we don't have details of what he has taken. No, neither do we have any radiograph or any sputum reports. So this is what the X-ray is showing. It's looking like bulle on this X-ray. You have multiple irregular nodular shadows here, right? So what is the thing that one should keep in mind here when you are going to look at investigating and starting treatment is that there has been irregular and inadequate duration of treatment. Just give me 1 second. I need to just figure out what's wrong with my internet. Yeah. Sorry. So remember, when we start investigating this patient, which we should look for all clues, because it has been a patient who has defaulted, there has been inadequate treatment. So the possibility of having developed drug resistance is much higher. Another case, 20-year-old boy, history of fever, on and off, weight loss, all symptoms for 2 months. Having had proper, his entire vaccination history in childhood is proper. But remember, what history he gave was that the mother is on treatment for TB for almost 15 months. Now, this should raise a flag, right? Because why is it that when we are looking at, while investigating patients, we have to look at the complete, because this would flag something that in today's day and age, we don't give drug-sensitive TB for more than 6 months, or maybe in some cases, if it's extrapulmonary, may extend it to 9 months. 15 months is rare. So possibly the patient's mother is on drug-resistant treatment. So not only will you ask him to get records of the old drugs, but you will also keep that in mind for him. So his X-ray look like what any other TB patient's X-ray would look like. There is a left upper lobe, patchy infiltrative shadow with some air bronchograms. There are some denser nodules as well. But remember that there is exposure to probable drug-resistant case. So do not forget to send the sputum for not only CPNAT, but also LPA first and second line, and also for a culture, and flag it that you have a third patient, 40-year-old male, reformed smoker, cough for 9 months. That's a long time. Generalized weakness, fever on and off. Some hemoptysis on and off for last 2 months. He has been on rifampicin and INH for last 7 months. So only 2 drugs for last 7 months. And this is what you're seeing. This patient has serial X-rays. So you're seeing that there was infiltrates in the right upper zone, in the left upper zone and the lower zone. There seems to be some cavity or retrocardiac that you're seeing with a little bit of pull up of the diaphragm. But what has happened subsequently is that there are new infiltrates on the right-hand side, and the left lung seems completely destroyed with multiple cavitations, right? So this is another thing that one should remember, that when patients come to you for follow-up, especially when you have patients with left-sided disease, where you're seeing evidence of volume loss early, these patients often also have bronchial involvement, which later on results in bronchial stenosis. I'm sure Karan would have mentioned this. And these are patients who then get cured of their TB, but then eventually they have all these, unhealthy sequelae, then which we are left with trying to resolve. So this would be a patient who has developed drug resistance. So when you have patients who have had inadequate regimen or irregular intake of regimen, that means very often when you ask patients, they'll say, "Nahi, we are taking it after breakfast. We are not aware that you have to take it on an empty stomach." Okay, it's a very small thing to ask a patient, but always remember to ask that. Wrong duration of AKT, whether they have discontinued it early. We've seen the second case, which was like that, the first case, which was like that, or somebody who has been exposed to to a household contact who's on drug resistant treatment. The regimen has been poor, or patient has been query buying spurious drugs. So there high chances of treatment failure and conversion of a drug susceptible TB into an MDR TB, right? Now, when this situation is where things can go wrong, because when you have a suspicion of MDR TB, and we land up sometimes wasting time in diagnosing, or there is an unregulated use of second line drugs. Say, for example, somebody just adds, which usually doesn't happen in the control program, but unfortunately all our TB treatment is still not only regulated in the control program, and in the private sector also there are multiple prescriptions that are going out of TB drugs. Somebody just adds one drug of second line drug to a failing regimen. Sure shot, very often these patients get converted into XDR TB. So adding inadequate regimen and inadequate drugs to a failing regimen again, or something that is not specified, unscientific, again is a disaster. So we have for drug resistant TB, these are the groups. You have the groups, or group A, where it includes the quinolones, levoflox, amoxiflox, bedaquiline, linezolid. You need to include all these three drugs when you're making a regimen for your drug resistant TB. Group B is clofazimine, cycloserine, or where you should include either one or both medicines. And group C drugs are usually used only when drugs from group A and B cannot be used, right? So these are most of the salvage drugs. The meropenem, amikacin, imipenem is used in salvage therapy. And you have dilaminate, ethambutol, and PAS, which are also part of the group C. So when you have rifampicin resistance detected, this is as per our National Tuberculosis Elimination Program. Please always request for a fluoroquinolone for LPA for first line and second line drugs, and also ask for a liquid culture with a DST. So when you have such a patient, do your pre-treatment evaluation, okay? Make sure which not only includes a physical examination, also includes an X-ray, includes an ECG sometimes, because especially when you're starting the patient on second line drugs. Look at the previous treatment history that is available, or you're looking at exposure history, household contact history, and see based on that with the LP results, if you have an additional resistance or an INH resistance, either with the CAT-G or an INH A mutation, but there is no fluoroquinolone resistance, patient becomes eligible for a shorter oral bedaquiline regimen, which contains, which we will discuss later. When you have a patient who has INH resistance detected with both CAT-G and INHA, and there is FQ resistance, then the patient, and based on the additional intolerance or non-availability, you could have a replacement sequence, which we will discuss subsequently. So as I said, drug-resistant TB, you have three regimes that are available. These are all oral regimes. Then you have patients, MDR in patients who are more than 14, you can go for the BPAL-M regimen, which is the first preference. When you have younger patients, then you could go for a shorter oral preference. the BPAL is between 6 to anywhere between 6 to 9 months. And then you have patients who are not eligible for the BPAL regimen should be assessed for the shorter oral MDR regimen. Or then when you have somebody who's ineligible for both of these, then you convert them for a longer oral XDR regimen based on the DST pattern. So what is a BPAL regimen, which is already rolled out and is doing well from the data that is available? Bedaquiline, pretominate, linezolid, moxiflox for 26 to 29 weeks. So this was a trial which preempted rollout of this, where they compared a 6-month BPAL-M regimen versus the standard of care regimen. And they found the standard of care was a 24-month regimen, and they found that it was superior to the previous long-term regimens. And it was a large-scale study. Do remember, however, that it is not really recommended in severe forms of extrapulmonary tuberculosis. So exclusion criteria for BPAL-M, if the patient is less than 14 years, there is a documented resistance to bedaquiline, linezolid, or on the DST, patient has liver disabnormalities, or as I said already, severe extrapulmonary TBs or severe conduction defects in the heart is when you would not choose a BPAL-M regimen, because this is basically got levoflox. It's got moxiflox and it has bedaquiline both. Now, the shorter oral bedaquiline containing MDR regimen for MDR patients is 9 to 11 months, okay, where you are giving patients linezolid, levoflox, clofazimine, pyrazinamide, ethambutol, INH, and bedaquiline, where you have a diagnosed patient of MDR or a rifampicin-resistant TB. There is no history of previous exposure to treatment with second-line drugs, okay, for more than 1 month. There is no extensive TB disease, no severe extrapulmonary disease, or women who are not pregnant or lactating. Okay, so these are the inclusion criteria for patients who will fit into the shorter oral bedaquiline 9 to 11 months regimen. What about the longer oral XDR TB regimen for 18 to 20 months? That means patients who are unfit. That means you have patients who are XDR patients or who cannot be given the BPAL or the shorter oral bedaquiline MDR TB regimen because either they are not eligible, there is additional resistance that is found in them. That means some of the second line drugs are additionally resistant. There is intolerance to some of the drugs available in the BPAL regimen or the shorter MDR, right? So obviously XDR patients, as I said, directly will go on the longer oral regimen. So what is this longer oral regimen? Is levoflox, bedaquiline, which is given for 6 months, can be extended to longer on a case-based, linezolid, clofazimine, and cyclosamine. So follow-ups are as important every month for shorter regimens, usually monthly in the intensive phase and then quarterly. Microbiology, every month till IP phase, similar to cultures. Cultures, remember, for shorter regimes, you do it for 3, 6 and end of treatment. Whereas if it is the longer regimens, then you are doing it till the IP, you do it monthly and then after that quarterly. So blood tests as and when required, may do a TSH and an LFT at the end of intensive phase and an LFT every 6 months. So ECG again, do it at 2 weeks start of treatment, 2 weeks, and then monthly till 6 months, and then as and when required, especially when there is bedaquiline in the regimen. X-ray at the end of IP and CT phase as and when required. Though I know this is what the control program recommends. However, I know that when patients become bacteriologically negative, put on weight, have less cough, less fever, but their X-ray actually sometimes starts showing new shadows, right? And Karan may have spoken about this, and I know for those of you who know me, I know I'm very passionate about patients who then develop very often left main bronchus stenosis, which then we have to subsequently do interventions. So I know for a fact that you have patients, this is a little bit of, in my personal experience, a bit of a conflict that when we are keeping such a long gap between the intensive and the continuation phase for a chest X-ray, that could be a little dicey. Maybe patients need to be then examined clinically better to see for any decreased breath sounds. And of course, color vision should be done for children every 2 months. Now, you can give a DST-based individualized treatment regimen in some patients when they're not able to fit into the standard criteria of the BPAL, the shorter oral or the longer oral regimen, especially when there are multiple resistance patterns involved, or there is intolerability. Then the drugs have to be changed according to the replacement sequences, and of course you have to give individualized regimens for special situations. So what is this replacement sequence? This is available in the National Tuberculosis Elimination Program booklet. It's a very extensive chart, but remember that if you have no intolerability, you do not need to replace drugs. That means that is a standard regimen. You're giving 3 drugs from group A and 2 drugs from group B. When you have to give one, when there is a drug to be replaced from one drug from group A, whereas group B, both drugs can be given, then you add a third drug from group C, right? For example, when you cannot give fluoroquinolone, then you give bedaquiline, linezolid, clofazimine, cycloserine, and add delamanid, which is the category C drug, for 6 to 8 months. Or then you give 12 months of linezolid, cycloserine, and clofazimine. Okay. When you cannot give bedaquiline, then again delamanid replaces the bedaquiline. So this is a little complicated chart, and similarly as you go down, there is many more permutations, combinations that you can follow. So this is a very good chart for everybody who is practicing treatment and initiating treatment or seeing patients on follow-up. This is a good chart to have as a ready reference, because sometimes So in special situations, your pediatric age group, these are some of the situations: pregnancy, renal. Let's look at each of these. So pediatric, it's a similar to adults, except when you have a child below 5 years, then bedaquiline is to be replaced by delamanid. Pregnancy, ethionamide is contraindicated till 32 weeks of pregnancy. Renal impairment, remember that pyrazinamide, ethambutol, amikacin, levoflox should be given as the pyrazinamide ethambutol has to be given as 3 times per week and not as reducing half dose to daily. Similarly, amikacin, levoflox can also be given 3 times per week in full dose. Cycloserine should be reduced to half dose daily or 500 3 times per week. In cycloserine, you have the option of making it half dose daily. And then, of course, the other salvage drugs the doses will change as per the creatinine clearance that you have to calculate. Now, pre-existing liver disease and resistant regimen should be avoided because there is INH, ethionamide, and pyrazinamide in that regimen. Remember, a lot of the drug regimens, rifampicin, INH, pyrazinamide, PAS, ethionamide, and bedaquiline are potentially hepatotoxic drugs. So one needs to look at these carefully. If you speak to your hepatologist, he will usually ask you to avoid pyrazinamide and ethionamide for sure, and then titrate some measure of the other drugs very carefully and see whether you need to replace them. When you have an INH monoresistance tuberculosis, then our regimen that we have been following all these years of rifampicin, ethambutol, pyrazinamide, and levoflox still continues 6 to 9 months. Some patients, surgery still has a role when, you can give it. There is unilateral resectable disease where there is no response to chemotherapy despite 9 months of treatment with proper drugs, proper schedule, proper timings, everything, etc. Or there is development of a high degree of resistance with extensive parenchymal involvement, or there is some comorbidities like recurrent infections, fistula, or hemoptysis, right? Now, coming to extrapulmonary tuberculosis, some things that we need to remember is that, for lymph nodes or pleural TB, 6 months of total duration is adequate. Abdominal TB, also 2 months HREZ with 4 months of HRE is adequate. Intraocular TB, they usually recommend extension of the continuation phase and continuing the extension phase with rifampicin and INH and avoiding the ethambutol for another 7 months. Meningitis, the duration of treatment of the continuation phase can be increased to 9 to 12 months based on the response. And again, skeletal TB is the same thing, that the continuation phase should be increased to 7 to 10 months. Now, remember, in the pleural disease, sometimes the isoniazid has good penetration. Moxiflox and levoflox also have good penetration. So in case you need to form a personalized case-based regimen, you could look at these options. In CSF, TB, isoniazid. Now remember, steroids, there are very clear-cut indications given by WHO on when one should use steroids in TB. So in TBM, they talk about giving steroids for 8 to 12 weeks with tapering. TB pericarditis, give an oral dose for 6 to 8 weeks with tapering. Intraocular TB can give topical steroids ideally, if needed systemic steroids, but here there is no recommendation on the exact duration. It will be based on the clinical response and in conjunction with your ophthalmologist. Miliary TB, 4 to 6 weeks, prednisolone. With Addison's crisis or adrenal involvement, it may be variable, and you may often need to give lifelong because the adrenal suppression always doesn't recover completely. With pleural TB, it is not routinely recommended, and it is conditionally recommended against routine use to be given only on a case-based basis, and if at all, for 2 to 4 weeks. Right? So this is important to remember, and they have also mentioned as some role of aspirin as a using in our control program. Now, this is what is happening, which is not yet available to us. This is what was published by the ATS. This is a study where they looked at shortening the drug-sensitive pulmonary TB regimen, where it was reduced to a 4-month regimen compared to our 4 months with 2 months of isoniazid, rifapentine, pyrazinamide, and moxifloxacin, followed by 2 months of isoniazid, rifapentine, and moxifloxacin. This is what this trial says, and of course, it is not rolled out in our control program. And we also have concerns in India because we have a high level of drug resistance, whether exposing our patients, and especially levoflox flox in the first line regimen would be ideal criteria. But because this talk is about recent advances, I thought one should mention about what is the data from the rest of the world. Of course, we can't conclude this without talking about TPT for beneficiaries of household contacts of drug-sensitive and DRTB and other high-risk individuals. So what the National Tuberculosis Program recommends is 1 month daily isoniazid and rifapentine, or a 3-month weekly INH rifapentine, or a 6 months daily INH, 3 months daily rifampicin and INH. If there is a patient who has MDR-TB with a quinolone sensitivity, then 6 months of daily levofloxacin. Or if there is a patient who has poly drug-resistant TB or an H resistance, then 4 months of daily rifampicin. Of course, there the patient, the case in the household has to be somebody who is rifampicin sensitive, right? So this we are talking about household contacts of patients who have, I think that is my last slide. Thank you.
Thank you, Dr. Pratibha, for an insightful talk about the various treatment available for susceptible as well as drug-resistant tuberculosis. And I think the government, the ENTER programs are pretty much strengthened now with the availability of universal DST expert or TrueNet at all the places, so diagnosis and as well as the case finding, plus the availability of the medications, which is almost free of cost. So I think we have Can we stop sharing the screen?
Yeah, that's what I'm trying to do. 1 second.
Sure. I'll just quickly try to answer the questions which was asked. Do we have any questions for Dr. Pratibha?
No, ma'am. Nothing that they've
Not at the
posted so
moment.
far. Yeah.
Okay. So somebody has asked, in TB patients who develop OADs, is ICS advised? So if you will ask me, ICS is not routinely advised for OAD in TB patients due to increased risk of MTB. But if it needs to be used in certain conditions, then you have to actually, outweigh the benefits than the risk, and with clear follow-up. I hope I answer the question. So routinely, if you will ask, generally it is discouraged use of ICs in patients with post-TB OAD, and if needed, it needs to be given with caution. Second question is PTLD patient treated like others? I think you want to ask that, is PTLD bronchiectasis is treated like the bronchiectasis in patients without history of TB? Yes. So post-TB LD bronchiectasis is generally managed with the same core principles as we manage the non-tubercular bronchiectasis. I hope I answered the question. And third one is, post-TB patients with isolated decrease in DLCO, what will be the differentials? So post-TB patients with isolated decrease in DLCO, if you ask very clearly, we should not be considering OAD in these patients. Most likely, we might have to look into whether, if there is an isolated decrease in DLCO, whether there are some pulmonary vasculature condition or some alveolar membrane condition is there, because of which there is decrease in DLCO. Other factor would be, look for the associated anemia, which can also cause isolated decrease in DLCO. Having said that, when the patients with the post-TB OAD in very early instances, some of these patients may have just an isolated decrease in DLCO to some 20 to 25% of those patients. So I think we need to keep a close follow-up, and we need to look, most commonly, we need to rule out the vascular causes, which could be the cause for isolated decrease in DLCO in patients with post-TB patients. So yeah, I think I answered all the three questions. Do we have more, Swapna?
No, ma'am. I think we can start the post session quiz.
Right. So we are starting, I hope everybody is ready with their phones. We are starting the post-session quiz. Is Dr. Deepak available?
Yeah, yeah. Sorry.
Dr. Deepak is
Hi,
there.
ma'am.
So
Yeah,
handing over to Dr. Deepak Prajapat for the quiz. Over
Yeah.
to you, Deepak.
yeah. So as
Uh,
we know that the pre-session was there, and now we are come up with the post-session quiz, and those who give the maximum right answer, they will get the Amazon voucher also. So please be attentive, and Swapna, can you share the
yeah,
post?
sure. Ravi, can you please share your screen?
So one thing is clear that whatever answers will be chosen by me as a right answer will be the right answer. So the first question is, which concept explains why a short course TB regimen require multiple drugs with different targets? Option 1, prevention of drug toxicity. Option B, targeting bacilli in different metabolic states. Option C is reduction of drug cost. And last option is enhancement of immune response. So I think people are voting. So can we move ahead for the second question?
Next.
So which post-TB lung disease phenotype is most strongly associated with COPD resembling? Option A is fibrotic scar disease. Option B is pleural thickening. Option C, bronchiectasis with airway distortion. And option D, calcified granuloma. Which post-TB lung disease phenotype is most strongly associated with COPD sampling?
Should we move to the next question?
Yeah. Next question. So the third question is, which emerging diagnostic approach may detect incipient TB before clinical disease develops? Option 1, interferon gamma release assay. B, sputum smear microscopy. Option C, tuberculin skin test. And option D, host blood transcriptomic signatures. So question is about the emerging diagnostic approach.
We'll move to the next question.
Yeah. So the fourth question is, which mechanism explains beta-glucan high-level resistance in Mycobacterium tuberculosis? So option A, mutation in ATP-E gene, mutation in RV0678 gene. Option C, mutation in EMBB gene, and option D is mutation in PEPQ gene. So the question is, which mechanism explain beta-glucan high-level resistance in Mycobacterium tuberculosis?
We'll move to the next question.
Yeah, move to the next question. So question 5, use of anti-TNF therapy increases TB risk mainly because option A, decrease antibody production. Option B, breakdown of granuloma integrity. Option C, due to reduced macrophage numbers. And option D, reduced complement activation.
We'll move to the next question.
Yeah, next question, please. So question number 6, which regimen is currently recommended for drug-resistant TB containing bedaquiline, pretomanid, and linezolid? HRZD regimen, BPAL regimen, DOTS regimen, and short course MDR regimen. So I think Dr. Pratibha did a good job in telling that which is the regimen, short course regimen for the MDR TB. Can we move to the next question? Yeah. So question number 7, the sterilizing activity in TB treatment is primarily attributed to option A is isoniazid, option B rifampicin, option C pyrazinamide, and option D ethambutol. So the sterilizing activity in TB treatment, it can be due to more than one drug, but which is the drug which is used in combination for the sterilizing activity in the initial phase? Next question. So which diagnostic test has the highest yield for diagnosing tubercular lymphadenitis? Option A, FNAC cytology. Option B, ZN smear. Option C, gene expert on lymph node sample. And option D is excision biopsy. Can we move to the next question? So which drug in BPAL regimen is responsible for nitric oxide release causing bactericidal activity? Option A, bedaquiline. Option B, Pretomanate, option C, linezolid, and option D, clofazimine. Now the last question. Which test has the highest sensitivity for tubercular meningitis for the diagnosis? Option A, CSF smear microscopy, CSF culture, expert MTB and rifampicin ultra, and CSF ADA. So which test has highest sensitivity for tubercular meningitis? So I think how many responses we are getting?
We have around 190, around 200 people who have logged in. I mean, they're responded. So can we end the quiz now? We'll
Yeah.
share the names of the winners in 3 minutes. So
So
maybe
in
you can
meantime-
explain the questions, and we'll share the name of the winners.
Just a minute. Yeah. So the first question was which concept explain why short course TB regimen require multiple drugs with different targets? The correct answer is targeting bacilli in different metabolic states. Why? Because there are heterogeneous bacillary population in TB lesion, and in the patient with tuberculosis, MTB exists in different metabolic states within various microenvironments of the lung. So there are rapidly multiplying bacilli for which isoniazid is the drug. For slowly or intermittently multiplying bacilli, the target drug is rifampicin. For semi-dormant bacilli or the persisters, the drug is pyrazinamide. And for extracellular bacilli, the target by ethambutol and other drugs. The second question was, which post-TB lung disease phenotype is most strongly associated with COPD resembling? The correct answer is bronchiectasis with airway distortion, because this phenotype occurred due to structural damage to the airways after tuberculosis, leading to airway obstruction, similar to COPD. And there can be a bronchial wall fibrosis, airway narrowing, peribronchial scarring, or small airway obliteration. And these changes can produce persistent airflow limitation. The third question was, which emerging diagnostic approach may detect incipient TB before clinical disease develops? The correct answer is host blood transcriptomic signatures. So it's an emerging diagnostic approach to detect early or incipient tuberculosis before clinical disease develops. And this technique is host blood transcriptomic signature or RNA expression profiling. So this approach measures the gene expression pattern in a peripheral blood that indicate early immune activation by MTB even before symptoms or radiologic disease appears. The fourth question was, which mechanism explain the beta-glucan high-level resistance in Mycobacterium tuberculosis? The correct answer is mutation in ATPE gene. However, there are other mutations are also there in the beta-glucan, but the high level of resistance is decided by the ATPE encode. Apart from that, there is a efflux pump upregulation, which is due to the mutation of RV0678 gene, and it is responsible for low to moderate resistance, and the PEPQ gene mutation, it is responsible for low level resistance due to the beta-glucan. The fifth question was, use of anti-TNF therapy increases the TB risk, mainly because the answer is breakdown of granuloma integrity. So the key role in the host defense against MTB for TNF alpha is the formation of granulomas, maintenance of granuloma structure, activation of macrophages, and containment of latent TB bacilli. So any one of them can be the reason for the risk of getting TB. The sixth question was, which mechanism explain the paradoxical worsening seen during the TB treatment in HIV negative patients? The correct answer was hypersensitivity reaction due to immune reconstitution. The seventh question was, the sterilizing activity in TB treatment is primarily attributed to which drug? Isoniazid, rifampicin, or pyrazinamide, or ethambutol? The correct answer is pyrazinamide. So there are drugs which are having a sterilizing activity, but the pyrazinamide is having a very strong early sterilizing activity. Rifampicin is also has a strong sterilizing activity, but pyrazinamide is having very strong. Apart from that, bedaquiline and pretominid also have the sterilizing activity. The eighth question was, which diagnostic test has the highest yield for diagnosing tuberculous lymphadenitis? The correct answer is excision biopsy. So these are the data. The FNAC with expert MTB having a highest sensitivity, but if the FNAC sample is inadequate, then of course the excisional biopsy is the choice for the correct diagnosis. The ninth question was, which drug in BPAL regimen is responsible for nitric oxide release causing bactericidal activity? The correct answer is pretominid. So this is the BPAL regimen. So B is for bedaquiline, PA is for pretominid, and L for linezolid. The duration is 6 months. The mechanism for bedaquiline, it inhibits the mycobacterial ATP synthase and block energy production. Pretominid, it is a nitroimidazole drug. It inhibits the mycolic acid synthesis and releases reactive nitrogen species in the hypoxic bacilli. And the linezolid is oxazolidine antibiotic that inhibits the 50S ribosomal protein synthesis. The last question was, which test has the highest sensitivity for tubercular meningitis diagnosis? The correct answer is CSF culture. So culture is always having a highest sensitivity as well as specificity, and also a gold standard for the tubercular meningitis. So thank you so much. And I think the Swapna, can we have results?
I've shared the names of the winners on WhatsApp to all three of you.
Thank you for teaching me today.
Thank you, sir.
I had absolutely actually I was attending it as a student today because I have no idea about all which you talked about today. I think I need to have more lessons on diagnosis and management of tuberculosis. Thank you everyone, and including Pratibha. Pratibha, once
I
again you
really
have
like the quiz, sir. I waited for the quiz. I learned a lot in the quiz. I think I should attend every time. At least one or two things new you'll learn, which you don't land up thinking otherwise.
quiz though was very difficult for me. It was very difficult for me. I've got the answers on which I'm seeing somebody has got 100% correct. I think that guy needs to be really I really need to meet him actually. Tapas Ranjan Behra. Where is he from and who is he?
Dr. Tapas, if you are online, can you please unmute or come on the camera, switch on your camera, please. I believe Dr. Tapas is winning the quiz for the second time.
इसको बैन करना पड़ेगा फिर. Others will never get anything. I think this is the second time I think he is getting. I think he is from Odisha. Is that right?
I think so. Dr. Tapas, are you still with us? Can you please unmute yourself?
I think he's a Manoranjan student.
Yes, I think so, Dr. Manoranjan Das.
And then second one is coming Romit Boro. Again, I think 89% correct. 9 out of 10. And the third one is Patra. प्रतापन पात्रा। इकट्ठे तो नहीं बैठे थे तीनों?
I think.
है? Are these three from same medical college?
Yeah, Dr. Patita Paban Patra.
Yeah.
I have an offer for Dr. Who's the first one, sir? Winner? I forgot the name.
Name is
After
Tapas Ranjan Behra.
Tapas, do you want to work in CMC after completing your MD?
Good afternoon.
Good
Good
afternoon.
afternoon. He is what? Sorry, I didn't get it, Richa.
No, I'm saying I'm offering. Do you want to work in CMC after completing your MD?
Correct. See, you get a placement also in the PG quiz, huh? So you are from where, Tapas? Where are you from?
SC Medical College, Cuttack.
Ah, Manoranjan only, na? Professor
Yes,
Manoranjan
sir.
Dash.
Yes, sir.
Wow, great. And is the other two people also your batchmates with you?
The third one, Patitavan Patra, is from our college.
And Romito Boro?
I don't know, sir.
Okay, so at least
They're not Googling the answers, no, sir?
there's no time. Actually,
Time
they have
to
answered in
Google.
11 seconds.
Yeah, there's no time to Google.
There is
No,
no
no,
time
because
to
one
Google.
answer
11
I had to
seconds.
Google and check. That's why I'm asking.
11 seconds they have taken, which is the average time for everything. So 11 seconds you cannot do anything. That means they are very, very knowledgeable.
Yeah, they're very good.
Congratulations.
Very, very good.
Amazon vouchers are on your way.
Congratulations.
And a
Congratulations.
placement at CMC.
Because this time the pre-session questions and the post-session questions are different. So
They're different questions. They're not the same questions.
yeah,
Some of them were changed, I suppose.
Okay.
Isn't it, Deepak?
yeah, 5 questions are different and 5 are the same.
So, Sapna, you have sent me this this thing, the pre-quiz or the post one?
This is the post quiz, sir, the final quiz.
Final one.
Yeah,
Wow. So this is very, very impressive. I must say that. So they're not only the Amazon vouchers, but yes, of course. Welcome to PAX and annual PAX. Of course, everything will be taken care of, all the winners. So thank you very much. I think Richa and Pratibha and Deepak and Dr. Sanjeev and Dr. Karan and everybody has talked so much today. Actually, I was the one who was absolutely a silent attendee today, and loved it actually. Thank you very much, everyone, and all the HODs, their postgraduates who have been a part of this third episode. It was a third episode, na Richa? Yeah.
yes.
So this was a third episode, and we are going to go for next and next and next. And our program director Richa is taking so much of pain in organizing this entire thing with such a precision that all topics are very well chosen. I'm sure that they will be enriching to everyone. And today another thing very good happened is, again, Richa, you have been able to keep a time very well. Actually, 4:30 you have finished it actually. So the first episode, I remember we finished very late, but this one we are on time. I think we are getting on time more and more. So with that, we'll see you all on the next episode next month. And I think Swapna, what is the date for the next one?
It's 8th of April, sir.
8th of April?
Yeah, 8th of
Oh,
April on
8th
Bronchial
April,
Crisis.
3 p.m. We will be back again with the next episode of Pulmoconnect. And this is the academic director, program director is Richa, and the guy who gives the prizes is Dr. Deepak Prajapati. If somebody wants to influence, please influence him. He might tell you the answers. He doesn't even tell me the questions. Today he was making the questions by sitting in an isolated room. He was not even telling me the questions. But I think he was. I think nobody from our department today could answer these questions, right?
No.
So it is like, of course, Deepak has not told even one question to anybody. Good. Thank you, everyone.
Thank you, everyone.
Thank you.
Thank you, everyone.
Bye-bye.
Thank
Bye-bye.
you.